Hey, Mike Gibson and Mike Reardon. We're talking about the 4-year results from the EVOLUT low-risk trial. What do you find, Mike?
Well, listen, thank you for having us on. We're excited to present this data. And we've all seen the explosion of TAVR, but we also see that, besides treating over 98,000 last year, we're seeing a lot younger patients being treated. The Vizient database now says 47.5% of the people under 65 are getting TAVR. So one of the reasons we wanted to report this more frequently than before is we think that in the low risk, we need to get the data out there. So we looked at a couple things. One is we looked before this at valve performance. We looked at structural valve deterioration. We presented at ACC last year, showing that there was more moderate or severe in surgery than in TAVR, and that if you had it, it doubled your all-cause mortality or cardiovascular mortality and your hospitalization. Steve Yakubov looked at overall valve performance, structural, non-structural thrombosis, and endocarditis, and again showed there was more dysfunction in surgery, and it was also associated with mortality and rehospitalization. So what we're really interested in is, do these valve performance metrics continue to influence the clinical outcomes? You've seen the data through 3 years, and at 4 years, what we see is the delta favoring Evolut over surgery has now increased to 4.4%. Never
Wow.
mind a 26% relative reduction of all-cause mortality or stroke for a p-value of 0.05. We all know that TAVR has an early advantage in mortality, stroke, recovery. The question's always been, will that advantage hold up? And now we're seeing for the first time, not only does it hold up, it's actually widening over time in favor of TAVR. If we take it and separate it into all-cause mortality or disabling stroke, we see it's driven by all-cause mortality. It's a 9% for TAVR and about 10.9% or 11% for surgery. I forgot the exact number. But again, it comes out to about 0.07 in favor of TAVR. So it's trending for TAVR. Whereas if you look at stroke, there's no difference. It doesn't increase late with Evolut, probably because of the very low clinical and subclinical valve thrombosis rate. So I find this very encouraging, my early data for this. Now, we're going to try to report the results every year for 10 years because we think in low risk, we don't really want to wait to do this every 2 or 3 years. And the field needs to know, because the field's already moving with or without us. We would like to give them the data to make rational decisions.
Well, that's just amazing. I mean, we all expected some early benefit, but you're saying in addition to the early event reduction, there's a continued widening of these curves late that continues in favor of TAVR. Uh, what do you think? What's the warranty on TAVR? I mean, if you looked, are we going to see failures 10 years later? I mean, do you
Well,
think this is a lifetime of benefit? Where do you think we are?
well, we're going to see biologic valve failures. If you get a biologic valve with surgical or TAVR, you live long enough, your valve will fail at some point. I think
Mm-hmm.
when we look at this and we look at mortality as you go along, the once you survive your procedure for your aortic valve replacement, whether it's surgery or TAVR, your longer term mortality is based on two things. What's your intrinsic risk level? And that's why you got to be very careful between comparing between trials because they're different populations,
Right.
and how well you repair the lesion, the aortic stenosis. Now, early on, most of this is your intrinsic risk, but as you go on, how well the valve performs. And one thing we've
Right.
shown with Evolut is you have superior hemodynamics at every time point, and you have less patient prosthetic mismatch at every time point. And those type of hemodynamics and the valve performance we just talked about will play a role in helping you live longer. So I think that we're seeing a couple things. One is the shape of both curves is influenced by the intrinsic risk level. The widening of the curves is the better correction of aortic stenosis by the evolute as opposed to surgery.
And you don't see any potential differential rate of failure for the two systems at the end of their lifespans.
We don't. We've looked at all the valves, and none of the valves we used have a difference in the primary endpoint. Now,
Yeah.
when you look at valve failure, people tend to look at it as a class effect, surgery versus TAVR, and it's not.
Right.
Surgical valves fail at different rates. TAVR valves will fail at different rates.
Okay.
But right now, we've not been able to say, okay, this surgical valve has influenced the data. Now, might one or the other do it as we move further out? That's why we're going to report the data
Right.
every year for you.
Well, it's interesting. We talked, oh my gosh, what are the early results? Now we're talking about the mid to late term results. It's good that we're now focusing even further into the future. I think it says good things about the technology.
Yeah.
Well, Mike, thanks for joining us. Congratulations. I'm thrilled to see those curves continue to diverge. Thanks for joining us today, and thanks to all of you in the audience for listening to us.
Well, thank you, Michael. We're excited to present our data.
Great.